learn more and more about your incredible program with ASAP and ICARP. So I wanted to start and just give some disclosures. I am doing studies in hospitals and nursing homes in which contributed antiseptic products are used. And I'm going to start with what you all know incredibly well, just to point out that when we look at our HAIs, the most common pathogens are things that are commonly on our own body. So here, Klebsiella Staph aureus, the #1 ranked one outside of the ICU, #3 in the ICUs, and everything else that you see on that slide is a common human commensal. If you look at ventilator-associated pneumonia, again, Staph aureus #1 in the ICU, and a lot of the other things there, common human commensals, and these are most recent data from CDC. SSI, again, Staph aureus, no surprise, at the top of the list, and again, most of those human commensals that are normally on our body. We also know that COVID did a real number on a number of our quality measures, and you can see here that when we're looking at MDROs, MRSA bacteremia, in the first year of COVID, quarter on quarter, got worse and worse nationwide. And finally, we know that we took a pretty hard U-turn. We were making great strides as a nation in a whole number of MDROs, and COVID, because of the enormous amount of antibiotics used for a viral pandemic, caused a huge U-turn in every single MDRO that is tracked nationally. So one of the key questions that we can ask ourselves is, well, how do these things spread between one and another? If we're going to try to stop the spread, we know that we as humans are an enormous plume of bacteria, and we just kind of shed in this cloud around us. And we know that when we do that, things fall into the environment. We're not great at cleaning. Things persist in the environment. And then if we don't clean our hands or we don't wear the right garb, we can actually bring things, of course, from one patient to the next. And we know that the highest risk of having an infection due to an MDRO is being colonized with an MDRO. So there are many things that we can do, or with vaccination, hope in the future that we can do to stop this type of transmission. But one of the reasons why I really like decolonization is because it actually starts at the outset of this entire cascade. So this idea that if we actually can stop this plume that we start with, if we can stop the shed of things into the environment around us, there have been a number of studies that have shown that actually if we can do that, we actually stop the environmental contamination, we stop the acquisition between patients, we can actually stop MDRO carriage, and ultimately stop infections. The other reason why decolonization is really important when we think about our armamentarium for infection prevention strategies is it is the only infection prevention strategy that does something for someone who already has an MDRO. If you look at everything that we do, wash your hands, clean the environment, wear PPE, everything is intended to stop something from going from someone who already has it to someone who does not yet have it. And when you think about the numbers of people, the growing numbers of people who have MDROs, it's really not a good place to say, you know, too bad for you, we're just gonna stop it from going from you to someone else. In addition, if you look at all the things that I just showed you about Klebsiella and VAP and all the things, you can see that actually we are our own worst enemy at certain times when we're highly vulnerable. These are things that are human commensals. So how can we do better? What can we do to prevent things that are normally just fine on our body and our gut, and then they can get really troublesome when we put ourselves into particular situations? So I'm going to tell you about the evidence for topical decolonization that are in place from large-scale randomized clinical trials, and we're largely talking about chlorhexidine for the skin and things that can clear Staph aureus from the nose, and that's usually either mupirocin or iodophor. I just want to start by saying that chlorhexidine has been around for a very, very long time. It was discovered in the UK, and then there have been a series of large-scale trials that have shown its value in a variety of things for infection prevention. I'm going to start here in the 1990s, where we know that Dennis Mackey showed across a bunch of trials that actually the best thing to clean the skin before you place a central line was actually chlorhexidine. We then move into the year 2000, where actually a large-scale clinical trial demonstrated that, again, chlorhexidine with alcohol superior to povidone iodine alone. And then there were a number of large-scale trials that demonstrated the high value of decolonizing people who were known to be carriers of Staph aureus to prevent not only postoperative Staph aureus infection from SSI, but actually all-cause nosocomial infections from Staph aureus after surgery. So I'm going to start the story by talking to you about things that are universal. That is, can we find high-risk populations that would benefit from just swapping out their soap and actually giving some nasal ointment to try to reduce the likelihood that these commensals of ours get us into trouble during high-risk periods. So we'll talk about the ICU. We'll talk about the non-ICU. We'll take ourselves a little bit into the post-discharge phase and then ultimately into the most recent data in the past year on nursing homes. So if we start with decolonization in the ICU, in 2013, 3 large-scale trials were published all in the same year in high-tier journals. And if you take a look at this one is the first one that came out. It was by Mike Climo in about 8,000 patients in academic adult ICUs. And what they did is they took these ICUs, there were 9 of them, and they actually randomized them to whether or not they would get chlorhexidine or regular bathing at certain times. So every ICU got both. They just couldn't choose when they got each. So that's the randomization design. And what they found is that they could reduce MRSA and VRE acquisition by 23%, all-cause bloodstream infection by 28%, and CLABSI by 53% by using universal chlorhexidine baths in the adult ICU. Then, this was the next study published same year by Aaron Millstone in pediatric academic ICUs. Crossover trial, very similarly done. They don't get to pick when they're using which product. And ultimately, they showed a 36% reduction in bloodstream infections in pediatric ICUs. And then ultimately, we did this large-scale trial. We took a bunch of community hospitals, and we randomized those hospitals to one of 3 arms, either routine care, and this is a community hospital trial of their ICUs. And so in the routine care arm, the ICUs were generally screening for, everybody got a nasal screen for MRSA. Those who were positive and those who were found out to be MRSA positive for any other reason were placed on precaution. So routine care was screen and isolate. The second arm was do that, screen and isolate, but now if you're found to have MRSA, you get 5 days of mupirocin and you get 5 days of chlorhexidine daily baths. And in the third arm, we stopped screening, and we said, everybody's critically ill, and so we're going to stop screening, save the money from that, and we're going to give everybody 5 days of mupirocin, and everybody is going to be bathed with chlorhexidine. So we had 43 community hospitals. This is part of the HCA healthcare system, 74 ICUs, about 75,000 patients, 283,000 ICU patient days. And because we had only 43 hospitals, which is a big trial, but you're only randomizing 43 units, not units, but hospitals, and all their ICUs did whatever that hospital was assigned to, it's really important that we actually control for the type of patients that these hospitals see. So everything was done in a way that's called a difference in difference approach. You take every hospital, you take their intervention period, and you compare it to themselves, their own baseline. That way you get some sort of control of unmeasured confounders, of the fact that different hospitals see different types of patients, and then you statistically do some fancy statistics to get the evaluation of the arm across the different groups. And this is what you get. So if you look at the x-axis, these are the 3 different arms. If you look at the y-axis, this is called the hazard ratio. That is every hospital's intervention period to its own baseline. So in the routine care arm, they're doing screen and isolate before, they're doing screen and isolate after. So you expect that ratio to be very, very close to 1, and that's what you see here. So arm 1, very close to 1, and then you see targeted decolonization better, and then universal decolonization even better with a statistically significant 37% reduction in MRSA clinical cultures attributed to the ICU. If you look at bloodstream infections, in the third arm, we were not powered for this, but I like this picture for a couple of reasons. One, what you want to see in any trial that you believe is working, you want to see all the bubbles come below the line. So here, every bubble is a hospital. the size of the bubble is the number of ICU patients that contribute to that data point. So you don't want to see one big hospital that's seeing the benefit and nobody else. You want to see everybody getting some benefit. So this slide I like because it suggests, even though we missed the p-value, it looked to us that if we could actually go longer or bigger, that we might have made a significant difference in the MRSA bloodstream infections. But I also show this slide because of the incredible disappointment of Arm 2. In Arm 2, you're screening everybody. And you can see that we don't even move the point estimate on MRSA bacteremia here. So screen, isolate, decolonize. You might ask, well, it's probably because one swab is not very good. It's about 65% accurate in picking up people with MRSA. This is this trial's kind of claim to fame. If you take a look again on the y-axis, routine care, for all-cause bloodstream infection, right around 1. They're not doing anything differently. Targeted decolonization, better, significantly better than routine care. Universal, better than both targeted and routine care, with a big 44% reduction in all-cause bloodstream infection in this trial. This trial had a bunch of papers that are associated with it, but the bottom line is it's incredibly cost-effective. It actually reduces not only real infection with bloodstream infections, but blood culture contamination. It reduces bacteriuria and candiduria, particularly in men, probably because the perineum is much easier to clean. But we did have active instructions to clean the perineum. This was used as the perineal cleaning as well. And again, big reductions in CLABSI reduction. And in 2021, CDC started to ask on the NHSN survey, are you using chlorhexidine and mupirocin? Are you actually doing decolonization? And in that year, 63% of US hospitals said yes, they had adopted universal ICU decolonization, and new data are coming out soon from 2022. So I'm going to move us outside of the ICU and take us to this trial. This is the ABATE infection trial. This is looking at something very similar, swap out the soap outside of the ICU, because if it had such a great impact in the ICU, can we actually do better? Can we prevent other things that are happening from people who are hospitalized? 53 hospital, 200 non-ICUs, and they had two arms, and we had two arms in this particular trial. One arm was do whatever you're normally doing, so offering daily baths, using regular soap on the regular non-ICU floors, and then the other arm was just to swap out what you use. So now, if you go into the shower, it's 4% rinse off chlorhexidine. If you're getting a bed bath, it's 2% leave on. And if they happen to know that you are MRSA positive, however they happen to know it, you got 5 days of mupirocin. So this trial was done very, very similarly, same thing, difference in difference approach, looking at key outcomes of MRSA and VRE together, as well as a secondary outcome of all-cause bloodstream infection. This trial had 340,000 patients, 1.3 million patient days. And what we found is that when you decolonize everybody in a community hospital, we didn't see a benefit for everybody altogether, but we did find a very high benefit in those with devices. So we defined devices by those that we could actually find in the EHR. In this system, that was those with central lines, midlines, and lumbar drains. So those were all readily available at the time we did this trial. And in those, we found a 37% reduction in MRSA and VRE clinical cultures, almost equal for both, about 37 for MRSA, 37% reduction for VRE, and a 32% reduction in all-cause bloodstream infection. This was important in community hospitals because people with devices were only 10% of the population, but they were responsible for a third of the MDRO cultures and 60% of the bloodstream infections, so a very high yield targeted group. I will say, as an aside, when this trial came up, I picked up the phone to my C-suite and I said, we're about to publish a trial that says that it's not particularly helpful to bathe people with chlorhexidine outside of the ICU. And we were a house-wide bathing organization. And my C-suite, smart, said, well, okay, but that's in community hospitals. So you tell me out of our entire system, because it's easier to do universal than targeted, you tell us what fraction of our patients are ICU, how many of them have wounds, how many of them are pre-op, how many of them are post-op, how many of them have MDROs, and how many of them have devices. And we looked at the numbers and we said, we're done. We're going to stay universal. So across the University of California health system, from Davis, UCSF, LA, San Diego, and Irvine, we are all house-wide for chlorhexidine bathing. But that's because we took the time to really figure out what our population was. And in a lot of community hospitals, that is not necessary for you to do, and you can target those with devices. One of the most common questions that I get is, how about we just do the bathing? Do we need to clean the nose? Because the nose is, it's kind of troublesome and it takes time, and you got to get the ointment, and the ointment is sticky, and there's resistance for mupirocin in certain parts of the country, certain parts of the world. So do we really, really need to do this? And so the answer is, well, that nasal ointment, whether you use mupirocin or iodophor, really is only targeting Staph aureus. So again, as I told you in the HAIs, Staph aureus is a pretty big problem for us, for a human commensal. It sticks around and it does wreaks a lot of havoc in our HAIs. So how much? So if you look in the ICU data, this publication came out in 2020, so it's very recent, and they looked at 1,100 hospitals across the world. And they said, take a day in your ICUs, tell me who's infected and what they're infected with. And then they put this up and they found that in North America, about 23% of infections in the ICU are due to Staph aureus. So we have a problem because it's a common commensal. So Staph aureus is not something to be dismissed. It's a pretty common pathogen, as you could see in the HAIs, and the nasal component is to target that particular pathogen. So pre-COVID, 120,000 Staph aureus bloodstream infections, 20,000 deaths per year, and sadly we are, as I said, we made a U-turn and we're a little bit higher than this now as a nation. So we decided to do a trial, and we said, okay, we've already done this big trial that showed that mupirocin, universal mupirocin, and universal chlorhexidine in the ICU drops bloodstream infections by 44%. So now let's do the trial where we say, how about we switch it with an antiseptic? We know that antiseptics are less prone to resistant small molecule, rapidly cidal. Pathogen doesn't have a lot of leeway before it's dead. And so we'll go ahead and do a mupirocin chlorhexidine comparison to iodophor chlorhexidine in a head-to-head non-inferiority cluster randomized trial in ICUs. So non-inferiority trials are huge. So this was a 137 hospital trial, 2 arms, mupirocin chlorhexidine, iodophor chlorhexidine. The nasal component was given exactly the same way, 5 days, twice a day. So exactly the same for both. And we looked at very similar outcomes to what I had showed you before. So as a reminder, this is done in the same health system that we had done the reduced MRSA trial in. When that trial had found that there was a big reduction in bloodstream infections in the ICU, their entire health system went live with universal mupirocin in the ICU. Every adult patient got 5 days, and universal chlorhexidine. So they were doing that for 8 years before this trial happened. So they're using mupirocin chlorhexidine for a very, very long time. And then we randomized, and half of these participating hospitals moved to iodophor. So this is what the sites look like across the United States. And this is not the final result. These are crude event rates, but I find it helpful just for perspective. So if you take a look on the left-hand side, mupirocin chlorhexidine, this group was using mupirocin chlorhexidine before and using mupirocin chlorhexidine after. So you don't see any difference. You can see that their crude event rates for Staph aureus clinical cultures attributed to the ICU is the same. And you look at the iodophor arm and you see that it gets worse. And so that is the answer to this trial, that if you look at the bubble plot of every hospital is a circle, every circle is the size of its ICU patients, you can actually see that mupirocin is in fact superior to nasal iodophor by about 18% for Staph aureus cultures. And if you look at MRSA, same thing, flat for mupirocin, worse with iodophor, and the answer for that is 14% worse for iodophor, mupirocin superior, significantly better than iodophor. If you look at all-cause bloodstream infections, the good news is because we were decolonizing, we didn't see a lot of bloodstream infections due to Staph aureus. So because of this, we didn't have a big effect in the difference between mupirocin and iodophor. So no difference depending on whether you used one agent or the other. And that's what you see here in the final answer, completely flat. Whether you use mupirocin or iodophor does not affect your overall ICU attributable bloodstream infections. So I want to take a moment and just show you in a different way what this means across a health system that was using this for 8 years. So one of the things you might ask is, well, 8 years is a really, really long time. And, you might be engendering, resistance by putting on the pressure, by giving mupirocin on a constant basis. So if that were to happen, you should see a decline in the benefit over time, right? So it starts out great, and then over time you lose it because, maybe resistance is being engendered. So I'm going to start you with the old trial for reduced MRSA, and what I'm showing you here is the decolonization arm in its baseline, where they were not using decolonization, and then in the decolonization phase when they picked it up. So same population, before they use it and after they use it. The dark purple circles are baseline. They're not using decolonization at all, and what you're looking at is the likelihood that if you stay longer in an ICU, that you pick up, you show that you have a Staph aureus positive culture. So across the x-axis, this is how long you stay in the ICU. The longer you stay, the higher your risk of having a Staph aureus culture that's attributed to the ICU. On the y-axis is this cumulative hazard, so it's not going to go down, it just accumulates. Your chance of picking it up over time, your very, very first positive culture for Staph aureus in a clinical isolate. If you then look at the lavender circles, that's after decolonization. So you can see that universal decolonization blunts that effect very, very significantly over time. Huge protective benefit the longer you stay in the ICU. Now, what happens if we take the trial that happened 8 years later, right? So there was an arm that did mupirocin chlorhexidine before and did mupirocin chlorhexidine after. We're going to take that exact trial 8 years later, and we're going to superimpose it to see whether or not we lost benefit over 8 years. And this is that line. So it is exactly the same. We did not lose the true benefit of getting Staph aureus clinical cultures to remain suppressed or removed or not even in clinical cultures across that period of time. Now, what about iodophor? Is iodophor, we know that iodophor is worse than mupirocin. Is it better than nothing? So if you actually put the iodophor line in, it's exactly what you would expect or hope to see. While we showed it was worse than mupirocin, it is statistically better than nothing. So the nasal product matters, and because the nasal product matters, that tells you that the nose matters. Those pathogens actually matter to the ICU and the type of infections that you're seeing. This is regular Staph aureus, all-cause, MRSA, MSSA. If you just subset to MRSA, you see the same exact thing. So no surprise, these things, whether they're resistant or not, the decolonization agents should be active. And if we look at bloodstream infection, as I mentioned, it doesn't matter which one you used, iodophor or mupirocin, and that's what you see here. And in fact, what you see is the later trial was actually better. Over 8 years, we got better at reducing bloodstream infections the longer you stay in the ICU. So what we found is that Staph aureus, it's a formidable pathogen. It is on our body, it's a human commensal, it's something that we're going to have to contend with whenever we're in a high-risk situation, like being in an ICU, like having surgery, like having devices. We know that mupirocin is superior, but there are times when iodophor may have some benefit. So what are those times? In my hospital, we use it when we have preoperative things to do and we don't think the person will go to the pharmacy, and they won't pick up that prescription and they won't pay the copay. So iodophor has a lot of benefits for being cheap, incredibly cheap. We actually package it for them and give it to them, but if they can get the prescription, that would be better. In the hospital, though, it's probably better you can prescribe things, it's easy to give, and so mupirocin is the better agent. We know that mupirocin alone works. So when we're asking the benefit of adding the nasal, there are tons of studies. This is a Cochrane review, but there's a ton of studies, lots of trials that show that mupirocin alone can actually reduce the risk of Staph aureus disease. And so we come to the conclusion, and these are a couple of small trials that I'm not going to be able to discuss, but we can see from the literature that solo chlorhexidine is great for preventing things from moving from one person to the next. It's a great transmission buster, but it doesn't do anything for the person who already has it. So 1/3 of humans carry Staph aureus at any given time. So for those people who carry it, mupirocin is needed to protect them from infection from the organism moving from their nose to other parts of their body and producing disease. So I'm going to move us out of the hospital and to talk about a couple of trials. So this is the CLEAR trial, Changing Lives by Eradicating Antibiotic Resistance. And this is taking people who have MRSA in the hospital. And it's not that they just have a history of it, but they actually have a positive culture, that hospitalization. Now, it could be a clinical culture or it could be a screening culture. So it doesn't matter what kind of culture, and we're going to enroll them into this trial. And they will get randomized to either education, hygiene, or education plus serial decolonization, and we will follow them for a year to see how we do. Why do we follow them for a year? So this is a study from the CDC, and if you look at time 00, that is discharge of people with MRSA. And what this is looking at is post-discharge infection risk. And you can see that when you leave the hospital, no surprise, your risk is still really, really high. And it stays high for 6 months for sure, but it really doesn't go back down to baseline for 1 year from the time that you're discharged. And it's probably because you're not feeling well. You need to basically, you're not clearing your secretions, you're not doing your hygiene, you're having things heal. So effectively, you're really quite at risk for quite a long time after discharge. So what we did is we took about 2,100 patients and we randomized them across this 1-year follow-up period, and they were assigned to either education alone or education and repeated decolonization. And what that was this. They got 5 days mupirocin in the nose, chlorhexidine to gargle, and chlorhexidine to bathe. Usually these are rinse-off showers. These are walkie-talkie people out in the community. And they did this for 5 days, twice a month, for 6 months, just to give them the protection during that high risk period. And then we followed them for a year. We swabbed them, they brought them back, swabbed them at months 1, 3, 6, and 9. We did a bunch of phone surveys asking them for whether or not they were readmitted to the hospital or had been diagnosed with an infection. Our outcomes were time until MRSA infection using CDC NHSN criteria, or time to any infection. So even if you didn't know what pathogen it was, any sort of infection. And then because we knew that not everybody likes CDC criteria, we did ID judgment. So we took 2 infectious diseases physicians, we redacted 8,000 follow-up records, and they were reviewed by 2 blinded infectious diseases physicians. If they disagreed, they had a conversation. If they could not agree, it went to a 3rd ID physician as the tiebreaker. So what we found is that if you look at the numbers of people with infection, there are less in the decolonization arm. The distribution of the type of infection once you have an infection is shown there. But this is what I want to highlight, is that the amount of infections involving bacteremia is really high. So Staph aureus, we think of it as like skin and soft tissue, but it can do, as we know, a lot of dangerous things. So about 30% involve bacteremia, 85% required return to the hospital. So pretty significant issues for these people. And if you look at all-cause infection, not just Staph aureus infection, again, lots of infections, 18% involved bacteremia, about 85% requiring return to the hospital. So this is the final answer for that trial. 30% reduction in MRSA infection, about a 17% reduction in all-cause infection. Very twin results, no matter whether you use CDC's criteria or a ID physician's gut check. And then we found a really nice dose-response curve. So if you actually take a look, we had people who stayed in our trial who were in the decolonization arm who would come to every visit, would be willing to be swabbed, and then they would tell us we did absolutely none of it. And so if you look at these people who did none of it, but they're in the decolonization arm, they do worse than the control arm. Probably because if they're not doing anything that we told them to do for our trial, they're probably not taking their diabetic meds, they may not be taking their hypertensive meds, but they're happy to see us. Then the other group that did the partial, and the people who did full. People who loved their chlorhexidine and loved their mupirocin, they had a big reduction, a 40% reduction in all-cause infection across that year. So it's important, as we know, if we can tell who's actually going to be compliant, these people do better for a variety of reasons. Small numbers needed to treat. Pretty remarkable given what we generally think of as the standard for, a couple hundred people for a number needed to treat, and if you're fully adherent, even less. So in the last piece, I'm going to move us out of the hospital and then into long-term care. So I'm going to talk about MDROs. We already talked about the fact that it's really our own bacteria that get us into a lot of trouble, but there are places where our own bacteria tends to look super resistant. So where is that? In hospitals across the country, and I dare say it sounds like you're better than the rest of the country in your MDROs, but that means that you have more of a protection, something to protect. We have 10 or 15% of people in a hospital have one of these MDROs. And if we look at long-term care and those of us that have done point prevalence sweeps across the country, so this would be us in California, Maryland, Wisconsin, Michigan, all of these places show the very same thing, that in long-term care, it is upwards of 50% of people have an MDRO. So as high as 65%. In LTACs, it's as high as 80%. So really, really high. Most of them are MRSA, ESBL, and VRE. Those are your dominant three. The rest of the things, for example, in California, we don't see a lot of CRE or CRAB, and it is 65% for us in Southern California, and Candida auris, sadly for us, strikingly on the rise. So this is a regional intervention known as SHIELD. What we did is we took Orange County, so our county is about 1.3 million people. We have about 100 nursing homes, 100 healthcare facilities, which are about 30 hospitals and about 70 nursing homes. And what we did is we took network analysis and we wanted to find those that shared the most patients, because those who share patients, you can actually reap some benefit, right? Maybe doing something together will be better than any of us doing it alone. So we actually extended invitations. We were looking for 40 people, 40 hospitals and nursing homes to actually kind of work with us. We extended about 57 invitations to get our 40-ish hospitals and nursing homes, 16 nursing homes, 16 hospitals, and all of the LTACs in Orange County, which were 3. And we did the following. For nursing homes and LTACs, because their burden of MDROs is so high, we said we're just going to swap everything out. Again, in your shower, you're going to get 4% rinse-off chlorhexidine. In the bed bath, you're going to get 2% leave-on chlorhexidine. And because it's hard to get a prescription and expense really matters, in the nursing home, you're going to get iodophor. It's cheap, it's easy, and it works. And we're going to give you 5 days on admission, Monday through Friday, every other week. Everybody, the whole nursing home does it together because Staph aureus is such a problem in that location. In the hospitals, they were already doing ICU decolonization. So what did we add? We added everybody in contact precautions. People in contact precautions, they transfer a lot. And so we decided to add that, and those individuals got daily chlorhexidine bathing, and they got nasal iodophor or mupirocin for 5 days, whichever the hospital was willing to do. And so this is what we found, and I'm going to focus now, because we've talked a lot about hospitals, I'm going to focus on the results from the nursing homes, 23% reduction in MDROs, and you can see that all of them on the upper corner are reduced. MRSA, ESBL, VRE. CRE comes down, but again, as I was mentioning in Orange County, our numbers are super small. I think this was less than 20 isolates for that estimate. Here's the kind of the final published data. This was just out about a little more than a month ago. So if you look on the left-hand side, that's all the MDROs. If you look on the right-hand side, everything to the left of the line is good. Everything to the left of the line means that we are actually able to reduce. And so you can see in the nursing homes, for a bunch of MDROs, whether it's gram-positive or gram-negative, we can actually get a good amount of them to be reduced on the skin. If you take a look at long-term acute care facilities, same thing, a whole bunch of MDROs on the left-hand side, and on the right-hand side you see a whole bunch of circles and lines to the left of that bar. and in the hospitals as well. And we didn't think we'd have a lot of effect in the hospitals because they stay for such a short amount of time. So you're starting decolonization, right, once they get there. And we just didn't think that, we're doing these point prevalence surveys. A lot of them are there for the first time on day 1 or day 2 of a hospitalization stay. But we actually could still see that we could drive most of, a lot of this, especially the VRE and ESBLs to the left of that line. Then we were interested in saying, okay, it's great. We've all shown that we can drop MDROs, but can we actually stop infections? So we took everybody in the nursing home in all of Orange County. So there were the 16 that participated and a whole bunch of nursing homes that did not participate. And we looked at the likelihood that people who were in the nursing home went to a hospital due to infection. And so on the left-hand side in the baseline period, you can see in the orange diamonds, those are everybody that participated in the intervention in their baseline phase. And everybody in blue are the nursing homes that did not participate. And then you see the phase-in period where we were loading in this decolonization intervention, and you can see that it switches, that the frequency of hospitalization in the intervention facilities, once they pick up the intervention, they now go from being high on the nursing home rate of infection to being lower than the baseline arm. So there's a big switch and ultimately a big drop in the amount of hospitalizations due to infections in this particular study. We found that actually not only could we drop hospitalizations by about 27%, but we could actually drop costs due to hospitalizations. Now this is cost for an insurer, but actually we can demonstrate cost saving in the nursing home themselves because those held beds are really a big deal. If you hold a bed for someone who's gone to the hospital, you don't get the $250 a day that Medicare will pay you to have them. And ultimately we also showed a significant reduction in deaths due to being admitted with an infection. So you might say, well, that's great, but that's not a trial. That is a regional intervention. That's a pre-post. Maybe there's a whole bunch of stuff that's happening that's making care better that might be timed with your intervention. So we did the trial. So this is the PROTECT trial, also published in this past year, 28 nursing homes, 14,000 residents, and these nursing homes were cluster randomized to one of 2 arms. Again, bathe however you bathe in whatever manner you normally do it with whatever you use, or swap out your soap, and we're going to give you 4% chlorhexidine in the shower, 2% leave on as a bed bath, and we're not changing your frequency. So in the long-term care, they do not get daily baths. They get them maybe full baths 2 to 3 times a week. That is the standard. In addition, we gave them iodophor. So very, very similar interventions between the SHIELD Orange County project and the PROTECT trial. So these nasal iodophors, they're soft, they're squishy, they are brown. We had to overcome a lot of people thinking, oh my goodness, you're gonna have all these stained noses. And we thought, oh, this is great. We can just walk down the hall and look, and we can tell who got it, right? Like great adherence. And you can't. It doesn't stain that much. You can't. You can't go looking around for brown noses to see if it was actually delivered. So here's what we found, that we could actually reduce, again, the MDROs. So on the left-hand side, you can see all of these pathogens. On the right-hand side, the drop from 1. So the top one, MDRO, 0.7 is a 30% reduction in all-cause MDROs, all of them coming down. And again, CRE, as I mentioned, we don't see a lot. You can see if you look at the numbers that it's about 20 in the entire study. So unable to make a determination. Here are the final trial outcomes. The very top row is the designed outcome for the trial. We were interested in stopping the reason. So if you're hospitalized from a nursing home, we don't want the reason to be infection. So we wanted to reduce the reason being infection. Same thing, if you're discharged from a nursing home, we'd rather you go home than go to a hospital. So we want to reduce the reason that you're actually leaving the nursing home as hospitalization. So we had a significant drop in infection-related reasons for going to the hospital, 17% reduction, and we had a 15% significant reduction in being discharged to a hospital. And then the New England Journal said, well, it's a little bit obtuse. Can you just give us a simpler number? Why don't you give us just the risk that a resident is going to be hospitalized? And so that's in the middle section. If you look per 1,000 resident days, a resident has a 31% reduced likelihood of being hospitalized for an infection and an 18% reduced chance of going to the hospital for any reason. That's a very low number needed to treat for the nursing home, and the big story is we can reduce 1.9 infection-related hospitalizations per month per 100-bed nursing home. It's a really, really big protection by just swapping out the soap and putting an antiseptic in the nose. So we have lots of tools that are online for those who are wondering, nursing homes are really low resourced. They're not mini hospitals. They really operate quite differently. They have different staffing needs. They have different resident needs. And overall, you really do have to approach it very, very differently. And for that reason, we have different toolkits for hospitals and for long-term care. What we know, though, is that if you just spend the money and plop in the soap, you will get no benefit. So that's been demonstrated time and time again, that if you do not train and you just load in the stuff, it's not going to do any difference. And that's because people make huge assumptions about the way that bathing happens. They assume that everybody knows how to bathe. So you don't have to train a CNA. You don't have to train a LPN. And that's not true, because they're fine. They've grown up cleaning themselves with intact skin, and then they look at this patient or they look at this resident that has lines, tubes, drains, incisions, abraded skin, and they have no idea what to do. And so what do people do when they don't know what to do? They avoid. They avoid it because it might hurt. They avoid it because we don't know how much to put pressure on it. And so ultimately, avoidance means that you don't clean the most important areas where the skin is broken and where things can dive in. So it's really critically important to train. The other reason is because you might wonder, well, why is this soap better than other soaps, right? This is the most studied soap known to humankind, is chlorhexidine at this point. And so why? And it's because if you clean your hands with alcohol hand rub and you clean your hands with soap and water, it's clean. Then you touch something and now you got to do it all over again. Chlorhexidine, if you massage it into the skin really well, it actually binds the proteins of the skin. And it will stay there if you do it well for up to 24 hours and produce cytal kill of invisible germs. And that's been shown not only to be benefiting the person who was bathed, but actually the nurses who actually have bathed them. Their hands are cleaner, and that's been well demonstrated in a number of studies. So chlorhexidine is a really powerful product because it continues to clean while they're sleeping, while you've left the room, that there are things that can be done to keep them safe. There are protocols that are out there. This is from AHRQ. This is our ICU decolonization protocol. There's a non-ICU decolonization protocol for those with devices. And then we have this one. This is from the SHIELD Orange County project, but it's the same thing as the PROTECT trial. And we have 3 toolkits: hospitals, nursing homes, and LTACs. And it's all free. So this is just an example of the enormous amount of free stuff that's out there for nursing homes. It has a QAPI plan. It has a letter to the patient's family. It has a letter to your ombudsman's teams. It's got all sorts of products. What are they? The protocols, the instructions on how to use. It has staff handouts for training, FAQs, everything you could want to know. Is it safe on wounds? Well, what happens if I have an allergy? What kind of allergies would we expect to see? Resident handouts, safety information. And we have it all in 2 forms, one with a PDF that has the CDC logo and a HRQ logos. It has all sorts of stuff on it. Then we have what I think is the more important one. It's editable. And you can take off all those logos and put your logo on it. And you can edit it in any way you want. And we did that on purpose because we want people to use it. This is just some of the examples of the training stuff that we have out there about how you would do this particular bath. Make sure that you clean all lines, tubes, drains, wounds from the body, unless, of course, it's so deep that it's packed. You don't want to do it for those. There's a ton of frequently asked questions and even checklists. So if you're going to take the time to watch someone, which is what we recommend, you can just quickly say yes, no, did they or did they not do the right things. We have now made some really free, nice modules for training for either non-CHG bathing, but also CHG bathing, and this is direct to provider. So these are CNA modules and LVN, LPN, RN modules. And in the nursing homes, they're not used to computer-based training modules, and so usually they'll just grab, put people together and then display it and walk through it on the big screen. We have training videos also that talk about how to talk to someone who says no. Does no mean no? Or does no mean I'm hungry or I'm in pain or, I'm cold and so I don't want a bath right now? So how do we handle refusal so you can make sure the difference between I really don't want to be bathed and I don't want that protected bath versus just not now? So in summary, we've shown that through a lot of large-scale decolonization trials that, in fact, it can reduce a lot of MDROs, gram-positive and gram-negatives, and importantly, the non-MDRO commensals as well that cause trouble when you're in a vulnerable place. Reduces bloodstream infections, hospitalizations, saves costs and deaths in long-term care residents. And these things are important. They are a swap out of the soap, but the nose can be really, really important if you're trying to reduce Staph aureus, either MRSA and MSSA. And so far, although we are monitoring thousands of strains coming out of our trials, we have not shown that the decolonization fuels resistance. Now, resistance is out there, we know from Pearson, but it's not differentially fueled by the use that we see, at least in our trials. But we can continue to look. We should continue to look until the next best antiseptic comes around. All right, thanks very much.